Good evening. You are watching Dr. KK's Med Talks non-stop show. Welcome to Med Talks Live, conversation that matter, an educational initiative supported by Eli Lilly. I, Dr. Anis Joseph, am your host for today's session. Obesity is no longer viewed as merely a cosmetic concern. It is now recognized as a complex chronic disease that affects overall metabolic health. Despite increasing awareness, many individuals continue to struggle with weight management even after repeated attempts with diet and exercise. This has raised important questions around when medical therapy should be considered as part of obesity care. In this episode of Obesity Talk, our experts will discuss the evolving science of obesity pharmacotherapy, who may benefit from treatment, and how early intervention can help to reduce long term health complications. This section aims to promote informed, stigma free, and evidence based conversation around obesity management. Let's start with today's session. Can we have obesity update video? Recent research highlights that obesity increases the risk of over 200 medical conditions, including heart disease, sleep apnea, infertility, and certain cancers. International obesity discussion increasingly emphasized early screening for MASH, NAFLD in patients with obesity and type 2 diabetes. At ECHO 2026, experts emphasized that obesity management should focus on organ protection, metabolic health, and long term disease prevention, not just BMI reduction. The ECHO 2026 suggested that greater weight loss with GLP-1 therapies may reduce the risk of heart failure, sleep apnea, osteoarthritis, and kidney diseases. So let's go to the topic of today. Now, let me introduce our guest for today, Dr. Gobinath N. Dr. Gobinath N is a renowned consultant endocrinologist with specialized expertise in endocrinology, diabetes, metabolism, and obesity management. He completed his MBBS and MD in general medicine, followed by DM in endocrinology and metabolism. Currently associated with Manipal Hospitals, Elanka and Herbal Unit, Bangalore. Dr. Gobinath has extensive experience in managing complex metabolic disorders, including obesity, diabetes, thyroid disease, and hormonal imbalances. He is known for his patient centric and evidence based approach towards obesity care with a strong focus on early intervention and long term metabolic health. His academic contributions and practical insights make him a respected voice in preventive endocrinology. Um, so, welcome to the talk show, sir.
Yeah, thank you, Dr. Anis, and good evening all. Thank you for having me.
So, shall we start with our first question, sir?
Yes,
So, the first question for you, sir: at what BMI should weight loss medication be considered?
yes. So currently there is so much of buzz going on around this weight loss medications. To be specific, GLP or dual agonist, that is GLP plus GIP agonist therapy. So uh, there are specific BMI cutoffs, that is body mass index, which is calculated by weight in kgs divided by height in meters squares. We get a value. Based on that BMI cutoffs, uh, we are initiating these medications. So currently, these cutoffs are taken from Western data. We don't have our own Indian evidence as such, but we are just taking the same data and starting the medications upon those cutoffs. To emphasize the cutoffs, uh, any patient with BMI of 30 or more without any obesity related complications can be started on these medications. If the patient is having BMI of 27 plus one or more obesity related complications, we can go ahead with these medications. But at the back end, we should also understand that this BMI is not an accurate indicator of fat mass in our body. Like we Indians, though our BMI is on the lower side, so we are having this increased visceral adiposity. So I feel personally, As Indians or Southeast Asian population, we are more prone for obesity related complications, and these cutoffs have to be much lower in our population.
Thank you, sir. I think the second question is a repetition of what you. Second questions. I think you have already answered, but I think just to highlight, I'm just asking you: are medications only for severe obesity?
Severe obesity, I'm assuming we are talking in term with as per the definition, we are talking about morbid obesity. As per the
Yes.
definition, BMI of more than 40, we label them as morbid obesity. Whereas uh, it's not only for those patients, any obese patient more than 30, I think we should consider more than 27, as I previously told, we can go ahead with these medications.
And for Indians, maybe a lesser cutoff
Correct.
based on their body fat percentage. Okay, so
Yes.
the
So
next question to you is: can pharmacotherapy be used alongside lifestyle changes?
yes. So we need to remember lifestyle changes like exercise, mindfulness, stress-free sleep, plus diet, whatever it is, either low calorie, low carb, high protein diet, should be our fundamental approach for managing obesity. And these medications will be an add-on. It's not an replacement for diet or exercise. This medication should be an add-on for the good diet and exercise. With that, in conjunction of all these effective exercise, diet plus medications, we will be able to get good results in terms of weight loss and further going on avail the benefits of glycemic control and other cardiorenal benefits.
Okay, sir. Thank you, sir. Just to highlight, you said BMI more than 28 with comorbidities, we should start medications. Can you explain which all conditions that you will consider while starting anti-obesity medications?
Yes, correct. So first and foremost, diabetes or pre-diabetes status, that is the most common prevailing thing, as India has become the diabetic capital of the world. After that, hypertension, BP levels of more than 140 by 90, or dyslipidemia to be specific, raised cholesterol levels, and other obesity related complications like obstructive sleep apnea, in common terms, snoring, or osteoarthritis, or any obesity related complications, we should think of starting these medications.
So PCOD also, the renamed term PMOS, do we start,
Correct.
do we consider?
Yes. PCOD patients, if their BMI is more than 27, we are going ahead with the medications, because PCOD patients, the issue is not only with specific to glycemic status or cholesterol. In most of the patients, what we see bedside, so either they will be married, planning to conceive, or with irregular cycles, or not able to conceive, or being evaluated for primary infertility. So the rationale of starting these medication in those patients are with good weight loss. Uh, if menstrual cycles become regular, if they become ovulatory, their chances of spontaneous conceiving will go up. So that is the reason we start these medications in PCOD patients.
Okay, most of the times when you suggest pharmacotherapy for patients, they feel like, is it a sign for that, lifestyle measure fails, that they have to be started on medications?
Not necessarily. It's not that lifestyle measures have failed. Uh, there are so many aspects for this statement. For example, uh, the biology of obesity per se, our body is built in such a way that it will, once we lose certain amount of weight with the help of diet or exercise, the body will try to go back to its own baseline state. The obesity biology is as such. So it's not that lifestyle measures have failed. We can also think like lifetime measures is not enough to just to sustain this weight loss. To help diet and exercise sustain weight loss further, we can add on these medications. So this is one part of the discussion. So in other part, there are so many other things, other aspects when we sit in a patient's chair and think. So when they are going about their routine daily activities, so some patients feel that they'll not be able to give their full uh, self to diet or exercise. Maybe because of, for example, if the patient is suffering from osteoarthritis, middle-aged or elderly female patient suffering from osteoarthritis, you can't expect her to do some moderate intensity exercise at least 30 to 40 minutes per day. Or for example, what set of patients I get, they say they are in front of PC, they are techies sitting in front of PC for 12 hours, 14 hours a day. They're not able to give enough attention to diet and exercise. In from patients' perspective, sometimes we need to understand their concerns, their issues, what they are going on with their lifestyle, and then accommodate accordingly, plus add on these medications.
Yes,
That should be our approach.
yes, sir. As you rightly said, starting medication on somebody is not a lifestyle failure. That is just an add-on to lifestyle measures. In some patients where they have resistant to lifestyle measures, adding these medications early would help. So next questions, when we start a patient on these anti-obesity medication, the common questions that we address every day is how do these medicines work in our body?
Okay. This medication act in our body at several points. To be specific, uh, this molecule GLP-1 analog, or GLP-1 to be specific, it is secreted from our small intestine after having food. This goes and then stimulates our pancreas to produce more insulin. It has some other pleiotropic effects also. So, so these medications, what they're trying to do is they're trying to mimic our own GLP-1, which is being secreted from our body, or in diabetics or obese patient, which is being secreted less, or it is being resistant. So by giving this, we are trying to mimic the same. So to be exact, how all it acts, so we need to understand it acts at multiple junctures. Firstly, it acts on our gut. It slows down our gut. The metabolism or the gut motility will be slowed down so that we are kind of full. Our satiety is on the higher side. And it also stimulates the pancreas to produce more of insulin. It also acts at the level of liver to reduce the amount of glucose output. And it also acts on the brain, which reduces our cravings or appetite. There are furthermore, I think that will be more complex mechanisms to understand.
As you rightly said, sir, it just not reduces the appetite. It has multiple levels of action which help an individual to lose weight. So, other common question which we encounter is: are these medications safe for long-term use?
Okay, so that is an valid question. Most of our patients come back to us with that question. So I think that is valid because for every new molecule, there is that which comes into the practice or market, there is initial skepticism from the patient side whether it's safe or not. So whatever data we have, so it's from last 10 to 15 years, they are safe. There are no any untoward or serious adverse events. Yes, there are some uh, noted boxed side effects. Again, the reason why we are using them in spite of those side effects or benefits clearly outweighs the side effects. And apart from that, there are some contraindications which I'll be telling further. So there are no notable serious side effects as of now from what data we have from last 10 to 15 years.
Thank you, sir, for highlighting that point. And the other common question is, how long should I be on pharmacotherapy? How long do I have to take these medications? This is one common question which we encounter in our
Yes,
daily practice.
yes. So basically, when we start this patient, these medications in a patient, so we need to understand uh, the disease per se, what the patient is suffering from. Maybe it will be only obesity or obesity plus some complications. We need to convey to the patient that these are lifestyle disorders. These are disorders which can be only controlled. There is no specific cure for these conditions. So the basic idea is, so we have to continue it for long. Yes, patients will question that why long or how long, because of either the compliance issues or financial issues. So before starting, what we should be clear in those patients are, so we should have a target at our back of the head. So maybe target in the terms of target weight or target sugar levels or HbA1c levels. So once we achieve that specific target, we try to reduce the dosage or keep the dosage in the maintenance levels and continue the same. Or even since the recent patent has gone off with semaglutide, there are cheaper versions are also available. So if the patients are unable to continue for long with the original versions, we can also try to keep them on uh, generic or biosimilar versions of semaglutide, to be specific. But the idea is it is for long term, because since it's lifestyle non-curable disorder, and we also need to understand that once I stop this medications, slowly the drug effect will also wean off. That is the bottom line.
Okay, and thank you, sir. And next question to you is, what are the common side effects that a person should be aware of while starting these medications?
Okay, so I'll start from most common, then I'll go to least common. Most common, it is the gastrointestinal side effects. Some initial side effects like bloating sensation, nausea, in few cases vomiting, diarrhea, or retching can be there. And in few patients, some occasional pain abdomen also has been noted, and the appetite or the cravings will go off. I've seen patients coming back and saying that, sir, I'm not having even appetite to have one meal per day. So that is also one of the effect what we have seen bedside. Coming to the more serious and rare side effects, yes, we have seen some occasional or rare causes of pancreatitis, being maybe if it was indolent phase or in the subclinical phase, maybe it got aggravated with the medications, or patient coming to us with pain abdomen and found out to have pancreatitis. On occasional, again, rare incidence of vision blurring due to some disc edema is also possible. But again, these are very less in numbers, maybe less than 1%. And if you ask me, is there any specific causal association established? Still, studies are going on. There is no actual causal association with these rare side effects, but caution is advised.
Okay. And these side effects you explained, sir, but in social media and internet and all, lot of information is going around regarding this vision loss and all. So, do they have to take any precautions, or when they start these medications?
Okay. So, precaution has to be taken from the medical fraternity side. Suppose when I am starting and weight loss medication, one patient. So, what? I need to grasp is how obese is the patient, and how uncontrolled is the diabetes state, and was there any previous history of any diabetic related retinopathy issues or not. So so the basic idea is, if there is rapid weight loss, if there is rapid sugar control, and if there was any evidence of background retinopathy, there are increased chances of developing this disc edema in these set of patients. So if I see any of these red flags, so first I refer the patient to an ophthalmologist to screen for any disc issues. Once it is cleared from ophthalmologist, then only we can start or go ahead with the medications. That should be our approach.
Okay, okay, sir. Thank you. Can medication prevent weight regain after failed diet attempts?
Yes, of course. So I think we have discussed earlier. So
Yes.
once we lose weight, uh, or after we have lost weight, the patient comes back to us quoting that though he is continuing with the low calorie diet, he is not able to lose much more, or the weight has become stagnant, or ulta he has started regaining weight. So, as I explained earlier, it's the basic biology of obesity or of our body which pushes to go back to its original state. So once we see that weight loss is being plateaued or not going up to the mark, we can add on these medications along with the diet part.
Okay, okay. Sir, you have said about the side effects. Just to highlight the point, who should avoid weight loss medications?
Okay. So there are some contraindications. So so generally these medications are approved only for type 2 diabetics plus or minus obesity. If the patient is having any pancreatic related diabetes or pancreatic stone related diabetes, this should be avoided. Again, in type 1 diabetes, it's still not yet approved. Again, studies are going on. If there is any family history of thyroid cancers, to be specific, medullary thyroid carcinoma, uh, or in the patient itself, if there was any a thyroid nodule history, or on examination you find a thyroid nodule, so until unless it is evaluated properly, we'll have to withhold the thought of starting these medications.
Okay, okay, sir. So, like you have seen a lot of this Amazon and a lot of alternatives. Like, are herbal or OTC fat burners safe alternative for anti-obesity medications?
No, clearly the answer is no. The rationale is simple. Today we are in the world of evidence-based medicine. So if someone asks what is the evidence, I can show the trial data or the previous data of last 10 to 15 years on GLP-1 analogs. First thing, regarding the over-the-counter medications or other supplements or weight loss supplements, these are not approved by the regulatory bodies. And what is the exact composition or what is the exact mechanism by which they act is not known. And on the flip side, we have seen patients coming with severe health issues after consuming these medications. So we urge the patients to avoid over the counter medications. Please consult a nearby endocrinologist, and only then they can go ahead with the supplements. There are some meal replacement powders. So for the education purpose of the population purpose, I'm telling, yes, those are specifically advised. Something like meal replacement supplements, which is of zero calorie or low calorie powders with good amount of protein supplements. Yes, they can be used, but it should the advice should come from an practicing physician or an endocrinologist.
Yes, sir. As you rightly said, it's better to avoid over-the-counter medications without a proper consultation with an endocrinologist. So, next question to you is, sir, how often should patients be monitored on treatment?
Okay, a very valid question. So once I start the treatment, uh, initial few days where the side effects will be silently kicking in those sort of patients, I would like to assess the tolerance at much frequent intervals. So initial 1 to 2 months, I'll ask them to come back at the end of first month and the end of second month, and from the third visit onwards, I will assess the patients once in every 3 months. So what I would assess is what is the extent of weight loss, the speed of weight loss the patient is having, and along with that, the metabolic parameters like sugar levels, HbA1c, cholesterol levels, and other inflammatory marker levels, how well they are improving. We will assess the patient as a whole, and uh, we will take the final call on whether to continue on the same dosage or increase the dosage or reduce the dosage likewise.
Okay, sir. Sir, you've already answered this question, but can pharmacotherapy improve metabolic parameters like sugars and cholesterol?
Yes. So it has shown, firstly, I would like to say these GLP-1 analogs or weight loss medication, it was approved initially for sugar control, for better glycemic control, and then found out to have good weight loss. Then the focus is shifted towards the weight loss. So, of course, we can use it for improved diabetes control and improved cholesterol, lowering of the cholesterol and other inflammatory markers like HRCRP or lipoprotein A. We have seen, we call it pleiotropic or other benefits of these molecules. We have seen significant drop in these markers as well.
Okay, sir. And many a times we will be able to reduce the diabetic medication dose once these patients are
Yes,
on
very correct.
GLP-1
Yes,
analogs.
correct.
So, the next question to you is, sir, what is the biggest myth about obesity medications?
Okay. Biggest myth would be I have patients, they read about um, they read about these molecules or they hear in social media and uh, come back to me stating that this medication will damage the kidney or damage the liver. So I would like to stress that these medications have been approved by all eligible regulatory bodies in India and rest of the world. So there is no direct link to any organ damage per se. On the flip side, these molecules help in preventing cardiovascular, renal, and even liver damage. And the second most myth, what I've experienced is patient want to take this medication for just 2 months, 3 months, then have uh, rapid weight loss because of some personal or social reason, uh, and they want to stop this medications. So we would like to tell that um, these medications are approved for specific indications only, as we have previously described. And if there is no proper indication for starting this medication, I think we shouldn't start this medications.
Thank you. So there are some audience questions. Can I just
Yes,
take them? And will I regain weight once I stop obesity medications?
yes. Um, So, like I explained, biology of obesity. So, the basic issue will be persisting. So, once I stop the medication, what are the beneficial advantages were there of these medications will be going away. Maybe there is an added advantage initial push upon diet exercise plus the add-on medication. Maybe we have achieved a good chunk of weight loss, but once we have stopped the medications, there are very good chances the weight will be regained. Again, at what interval? the patient will usually regain the weight. Again, that is again very subjective. We have seen patients able to maintain weight for a good chunk of 6 months, 1 year, and some few patients even 2 years without the medications. Later, they started gaining weight. But once we stop the medication, the benefits will go away and weight gain will occur.
Okay. I think Ms. Arpita has asked a question. How long should someone try diet and exercise before consulting obesity doctor?
Okay. So I would uh, put the patients on strict diet and lifestyle at least for 3 months. I would want to assess how well the patient is able to sustain a low calorie, low carb diet and plus moderate intensity exercise for 40 minutes, 30 to 40 minutes per day for 3 months. And I will see how well the patient is losing weight and how well the patient is coping up with this newly changed lifestyle. Only after that, I would like to start these medications.
Next question is: can semaglutide be started in children and old age?
Okay, children and old age. Yes, as per the latest data, I'll first tell about children. As per the latest data, uh, it is approved for age, to be specific, I'll have to go through the data, but uh, liraglutide is one GLP-1 molecule. It was approved for adolescent type 2 diabetics also. I think the age cutoff was 11 or more. Again, the recent data on semaglutide is yet to come out. We should be able to get that data, but any child with 11 or more, we should be able to use this medications. Old age, of course, we can start, but in old age, like I initially said, certain red flags about the vision and the pancreatitis or other active tumors or thyroid nodules should be assessed. Once we rule out all these conditions, we can go ahead with these molecules in old age also.
Thank you, sir. Then the last question for you: what is the maximum dose of semaglutide?
Okay. So we usually start with 0.25. From 0.25, we increase slowly to zero point 0.5, then 1, then from 1 to 1.7, from 1.7 to 2.4 milligram subcutaneous every week. 2.4 milligram is the highest dosage of semaglutide.
I think that was your last question. Thank you, Dr. Gopinath, for joining us today. And that will be all for today. Dr. KK's Med Talk will return tomorrow at 7 p.m. with another edition of the show. Keep watching Dr. KK Med Talks. Namaskar.
Thank you, Dr. Anis. Good evening, all.
Good evening.